So again, about Guttate psoriasis. These are my disclosures. They do not have any relevance for this talk. All my slides are mine and are my opinion and my vision. So we do talk a lot about plaque type psoriasis, and when you know that classical plaque type psoriasis is driven by this pathway of TNF, IL-23. I'll quickly take a pointer. So this pathway of TNF, IL-23, and then IL-17, so T cells producing IL-17, and this is the key driving pathway in psoriasis. And this is not just hypothesis, so this is a project we started here in Lausanne and the guidance of Michel Gier, and you can see every column here is one single patient with a different gene expression, and you can see in red are the genes which are overexpressed, in green it's absent or not present, and you can see different type of inflammatory skin diseases, and you can see they all cluster together based on the expression profile. And why I'm showing this is because you can see plaque type psoriasis really has a very strong Th17 signature, while there's more or less nothing else present. So classical plaque type psoriasis is really driven by an activation of this Th17 pathway and this Th17 signature. And this was clear then obviously that targeting this pathway is critical in plaque type psoriasis, in particular the last 5 to 10 years. The anti-IL-17 and IL-23 blockers came onto the market, and nowadays we really stratify our patients on an extremely high level based on patient-related factors, for example, being a very severe skin disease, if you need a fast onset, if they have PSA or not, if they're obese patients or not, presence of IBD and so on. We really do stratify our patients on a very, very high level, as it becomes almost difficult to have non-responders as of today. But not only just for biologics, but in general, if you want to look for the best optimal care of your patient, there's a lot of factors that weigh in on your decision, and it's clear that no single treatment option is appropriate for all patients. And there's drug-related factors such as safety and efficacy, obviously, that we take into consideration, the patient-related factors. And today we're going to talk about one thing, a disease-related factor, and that's the particularly on the phenotype and variant that are present. And today we want to talk about, or me at least in the first part, on Guttate psoriasis. So this is mainly on plaque type psoriasis, where we know this pathway of TNF, 23 and IL-17 plays a major role, but we do have other types of psoriasis. There's acute psoriasis, dermic psoriasis, where we do know that in type 1 interferons or interferon alpha, which is produced by plasmacytic dendritic cells, are overexpressed. This is in plaque type psoriasis a transient effect, so you have during the development of a new lesion, short-term type 1 interferon then gets relayed by this chronic pathway. But in acute forms of psoriasis, the dermic psoriasis, you have an ongoing acute inflammation driven by type 1 interferon. And the other end, you have pustular psoriasis, where the neutrophils obviously play a major role, and we know this IL-36 IL-1 pathway plays a major role in that regard. So we have three major pathways active in subtypes of psoriasis. In chronic plaque type psoriasis, the 23-17 mainly, pustular psoriasis, IL-31, 36 IL-1, and the acute inflammation being driven by type 1 interferon. So we do stratify already nowadays based on the clinical presentation, the future, hopefully also on the molecular presentation or the endotype of a patient, and then we take a more targeted approach, or if needed, a broader approach, so synthetic DMARDs, and we do have actually treatment in all that regard. So we do have 23 blockers, 17 blockers, particularly for psoriasis, plaque type psoriasis, IL-36 blockade in pustular, and then, for example, TYK2 in acute psoriasis. And depending on where they are, if there is sometimes also in between, you want to have a broader approach and maybe go for something like a Premilast or TYK2 inhibition, where you block several pathways at the same time. So this is a bit the basis on how to choose the therapy. And now, what about Guttate psoriasis? So guttate, you all know that gutta is a Latin and says drop. That's why we have this drop-like lesions. You have really with a sudden onset, you have an eruption of these multiple small, these drop-like psoriasis lesions, which typically are distributed over the upper trunk and the proximal extremity. So we have this centripetal distribution or evolution, which typically is, as I mentioned, acute onset. However, it's not the same as small plaque type psoriasis, which is a subtype of psoriasis, which is particularly seen in Asian patients. With a later onset, it's less common in children and adolescents, but typically in later patients. And what you do not have is also a clinical presentation. It's a more stable presentation. Everything is not the same. Guttate psoriasis has the strongest association of all the subtypes with an HLA-CW6. So T cells might play a more important role in this type of psoriasis. And as mentioned before, it's more common in children and adolescents. It is not the most common form in children and adolescents, as often stated. There's still 2/3 of the patients with and pediatric patients still have plaque type psoriasis as their most common form, but nevertheless, it's much more common with about 20% of the patients in pediatric cases or guttate psoriasis. As mentioned before, it has an acute onset and typically is triggered by streptococcal throat infection. There are other streptococcal infections such as perianal infections, but also viral infections which can induce it. The swabs are usually or often not positive. However, if you look on a molecular evidence, you can find in more than 50% of the cases, such as Oslo titers or anything, you can find a positivity there, depending on a study between 50 and up to 90% of the patients do show a recent streptococcal infection. However, and this is already a bit the beginning of the discussion, antibiotics seem not to be beneficial. It's highly debated, but in most cases, in RCTs at least, antibiotics seem not to be beneficial in the management of guttate psoriasis and particularly do not alter the disease course in the future, at least as we know so far. So about the disease course, guttate psoriasis is a very good prognosis. It's often self-limiting. That means there's a resolution by itself, even without therapy, within a few months, in the range of about typically in one study between 1 and 8 months, usually about 3 and 4 months, and there's a spontaneous resolution again. So if you look at the data, it's a nice study some 10, 15 years ago where they looked into these patients, so they have acute flares in about 60% of the patients. And again, this we have to take into consideration when choosing therapy, but 60% of patients do show this rapid resolution within less than a year, typically within 6 to 8 months, the patient are in remission again, and they do show long-term remission for a longer period of time. Some of the patients never show a flare again in the future. Sorry, that was a bit too fast. On the other hand, 40% will go on into a chronic disease without remission. So they, even with therapy, they usually do not go into complete remission afterwards. And then some of them, they remain as an ongoing guttate psoriasis with rapid recurrences, with rapid flares again, or never in complete remission at all. And then one part of the patient will actually develop chronic plaque type psoriasis. This is still one of the big debates, how many patients are actually going into develop chronic plaque type psoriasis. There was a very recent study which is still not officially out yet by Diamantacci, another IPC counselor, who have studied this in a huge retrospective study with 190,000 patients. And there they found that after one single flare of guttate psoriasis, you have about a 12.5% risk of developing plaque type psoriasis. And other studies have looked into these patients here, so the chronic ones, and there it seems that in the range of out of 5, 6 patients, up to maybe 1 out of 3 patients actually develop chronic plaque type psoriasis. In general, it seems like the rapid resolution group is usually younger, so the earlier the onset, the higher the chance that you go into this rapid resolution and long-term remission. And also the higher the Oslo titers seems that is prognostic wise a good factor. On the other hand, and not surprisingly, to be more in the chronic disease and then developing chronic plaque type psoriasis, the positive family history was the major factor deviating you into this group. So what about now about the pathogenesis or the underlying signature? We heard it's an acute onset, it's an acute inflammatory disease. And we know that erythrodermic psoriasis is mainly driven by type 1 interferon, so interferon alpha. And we know that unstable psoriasis has a bit of both. So they have in the periphery where the lesion is growing, you find type 1 interferon, you have the PDCs, not so much T cells, but in the center of the lesions, you do have the chronic plaque type psoriasis, and you find T cells and a lot of Th17. So where does guttate psoriasis fit in? And this obviously then has an effect on how to treat our patients. And what we find is that there's a study by Fanny Saidun here in the lab has done. And what we find is that all of them do show, so plaque type psoriasis and guttate psoriasis, strong Th17 signature. And while absent in classical plaque type psoriasis, in guttate psoriasis, you do find the presence also of type 1 interferon signature genes or the type 1 interferons themselves. So it seems really that you have this acute phase as well. So you do have a combination of acute and chronic plaque type psoriasis in guttate psoriasis. So what does that mean also for therapy? It's actually interesting that two of the most commonly used therapies used in guttate psoriasis, phototherapy and cyclosporine, which show efficacy, they actually reduce this acute phase as well. So phototherapy depletes the PDCs from the skin, so they do not produce interferon anymore, and cyclosporine reduces the production of type 1 interferon by the PDC. So you do have an effect on both the chronic and the acute phase, and it does make, obviously also from pathogenesis point of view, sense to use the therapies in guttate psoriasis. Another approach to target both type 1 interferon and Th17 pathway is TYK2 inhibition. That's a drug that has been entering the market about 2 years ago. Deucravacitinib is an oral selective TYK2 inhibitor, so it blocks the transmission of a signal from the outside, from a cytokine into the cell, uses the JAK-STAT pathway, and the TYK2 is the fourth JAK member. And if you block TYK2 with deucravacitinib, you block simultaneously the Th17 pathway through IL-23 blockade or inhibition, and you block the acute phase type 1 interferon as well. So you block both pathways simultaneously. There's no study in guttate psoriasis, and the drug uses a bit longer to actually show its efficacy. It's not the fastest drug, but it's solid. But it could be an interesting approach in guttate psoriasis, particularly also the ones which have a chronic disease course and recurrent flares or never go into remission, that if maybe TYK2 inhibition is an option in that regard. But in general, if you think about therapies for a chronic disease, and this not holds true for guttate psoriasis or psoriasis alone, but in general, anything that is chronic and doesn't, no cure is available, you have to find that option for every single patient which offers the best benefit to risk profile. And so we have to consider that guttate psoriasis, at least 60% of the patients have a very beneficial outcome and have a self-limiting disease course. So you're probably not going to go into very aggressive therapy. So this was another recent review paper by Ron Bender and some of his Canadian colleagues, who's nicely reviewed the management of guttate psoriasis. And typically what we use thinking about this self-limiting and good prognosis of guttate psoriasis, nothing aggressively. So usually it's topical corticosteroids, phototherapy. The problem with topical steroids, obviously, if it's widespread, it's hardly or impractical to use. Phototherapy is excellent first-line therapy, usually works very, very well, but it's not good for actually relapse prevention. So it's not something for a maintenance therapy if the disease is ongoing. A second-line therapy, if phototherapy is not feasible, or if it's too widespread and phototherapy is not feasible, then methotrexate or cyclosporine. Both of them have solid data. It has to be said that there's, in general, for guttate psoriasis, very little evidence. Very few studies have been performed. And only a third-line therapy, the biologics, given the natural course of the disease, price of the drugs, it doesn't make sense to give them right away, but maybe in some really refractory diseases, this is certainly also an option, and particularly also in the future, maybe small molecules which can be given for a certain period of time and then stopped again and then given again down the road. And now a little bit the elephant in the room is actually the anti-streptococcal treatment. So what is that about? So the anti-streptococcal therapy, meaning that antibiotics or tonsillectomy. So what is the rationale behind it? So why would you give it? And obviously you have the streptococcal throat infection being the major or most important trigger factor for guttate psoriasis. And we do know that the T cells play a role. So we have this HLA, C6 association, and we have a considerable sequence homology between streptococcal M protein and human keratin 17 protein, so protein expressed in the skin. And it thought that the streptococcal superantigen are therefore able to stimulate the expansion of T cells, which then actually induce psoriasis through what we call molecular mimicry. However, this makes sense then to treat the streptococcal infection. However, and again, this remains mixed, this remains debated, but at least most controlled trials do not support the benefit for antibiotics in the management of guttate psoriasis and do not alter disease course. There's positive data on rifampicin, but this is independent of an infection, so it's never been shown that it could be beneficial in these cases which are really infected. So this there are certainly still some data needed. On the other hand, tonsillectomy, and this shows actually positive results in almost all the studies performed in case series. However, there's obviously some side effects or risks with the tonsillectomy. So this has to be discussed as well. And it's not just guttate psoriasis which shows a benefit after tonsillectomy. So the question remains a little bit, why is there a discrepancy between antibiotics which delete or deplete the bacteria and tonsillectomy? And one thing could be that you're actually the bacteria just activate the tonsils, you have inflammation, and this then leads to activation of T cells which go into the skin, such as through molecular mimicry. We went another way and looked actually at autoreactive T cells which could be activated in the tonsils. And what we found is that HBD3 directed T cells, so against antimicrobial peptide human beta defensin 3, which is both expressed in the epidermis and in tonsillar keratinocytes. And you can find them in psoriasis patients, but you preferentially find them actually here in red in flares of guttate psoriasis. So it could be that the activation of the tonsillitis itself leads to upregulation of these antimicrobial peptides, activating of T cells, which then go into the skin and induce these flares. So this could explain this discrepancy between actually tonsillectomy and anti-streptococcal or antibiotic therapy. But in general, I think, and that's why the discussion is ongoing, the benefit of it is still highly debated, because if you use repetitive antibiotics, obviously this increases the risk for antibiotic resistance. So benefit again might be disputable, and obviously also with tonsillectomy, this has a risk or morbidity and even mortality, particularly in children and adolescents. So this really has to be weighed against the potential benefit for every single patient, and really might be reserved for really recalcitrant psoriasis. And so with that, I'm coming to a little bit the end, and you obviously see there's still the need for a lot of data, and we still don't know which patient population actually goes into resolution and which patient population goes into the chronic phase and potentially also into chronic plaque type psoriasis. And here the Skin Science Foundation is now starting probably next year a multicentric European study where they look at over 2 years with 40 guttate psoriasis patients just with a very single first episode of guttate psoriasis, and then look into genetics, metabolomics, proteomics, transcriptomics, microbiome, and then see which patient, how to define in which patient population they go. So there should be in a few years some new data on guttate psoriasis. With that, I'm already coming to my last slide, and shows that guttate psoriasis is really a subtype, as mentioned, with an acute onset, with an acute eruption, often triggered by streptococcal throat infection, most common in children, adolescents, and young adults. But have in mind when thinking about the treatment that is mostly a self-limiting a disease course with long-term remission, even though about 40% go into a more chronic course and need probably long-term treatment. First-line therapy is obviously topical steroids and phototherapy, depending on the course, then going into more chronic diseases, more chronic treatments. But again, it's more or less the same as in plaque-type psoriasis. And again, I'm not going into details, but anti-streptococcal therapy remains highly debuted, and the benefit needs to be evaluated in each patient. And with that, I'd like to thank you for your attention. I'm not sure if there's any present questions from the audience. I'm going over to Peter, and otherwise I'll directly hand over to Thiago.
Are there questions? Thank you so much for this this very important talk. I think it's important to move to, with respect to the pathogenesis of psoriasis, to the subtypes, and you give here attention to unstable psoriasis, to guttate psoriasis, and also how this impact actually treatment selection. I have myself a question that is regarding deucravacitinib. Has the company analyzed their data with respect to the subgroup of patients having unstable disease? This may be difficult to extract that from the database, but when you look at those patients who show aggravation of the disease during washout versus those patients who are more in a stable phase of the disease, do you know whether there is some signal from the clinical trials that deucravacitinib might have an important role here in this in patients with an unstable phase of the disease?
To my knowledge, this has not been looked at. But what's interesting, they have this washout, so they have the withdrawal data, and there it's the effect. You have a drug which is given daily, but they have about 30% of the patients almost that remain disease-free for a very long period of time. So it might be that blocking the acute pathway, you actually prevent recurrences or relapses. So this is an interesting approach, and this would be something which would then be potentially beneficial for guttate psoriasis, unstable disease, maybe also small plaque-type psoriasis. Even though it's different, this is also driven by type 1 interferon. So there are certainly some things to look into and some things to learn. The problem with guttate psoriasis, given their heterogeneity, you need a lot of patients to do any studies. That's a bit what probably is the drawback for the companies.